Hello, everybody. Good evening, everywhere you are. It's a pleasure to be with you tonight, and we want to thank you for joining us for this monthly CIA's Case Conference webinar. This is our November monthly webinar, and we want to thank you all for joining us, and we want to welcome you to participate and just chime in with these two cases that are going to be discussed tonight. So before we introduce our presenters and our mentors, we want to do some housekeeping announcements. We want to make sure that you remember that the trainee membership for our CIS is free, and we want you to just be part of this community. So please join us and make sure that you check it out at the webpage, and we'll post it in our chat. And I think without further ado, we're going to introduce the first presenter. Her name is Malvika Kapoor. She's one of the second-year fellows at LSU Health Shreveport, and she will be presenting the first case. And we had the honor of having Dr. Ivan Chin as our senior mentor for the case. He's an assistant professor at Baylor and the director of immunogenetics at the Texas Children's Hospital. So thank you both for joining us tonight with this case. And please feel free to send all your comments and questions, and any participation is highly welcome. And we'll be checking the chat and making sure that we follow all your comments. Please don't hesitate to participate. So take it away, Mel.
Hi, everybody. Thank you, Dr. Valdez, for that introduction. So my case is entitled Beyond Genetic Testing and Prophylaxis. And thank you again to our senior mentor, Dr. Chen, for all his help on this case as well. So our case is a 73-year-old female who presented to the AI clinic for evaluation of low IgM and recurrent infections. So the story is that after she was placed on doxycycline after a bout of basal cell carcinoma of the eyelid, she developed persistent thrush for the last 3 years. She was placed on fluconazole, and she has been seen by infectious disease who recommended that she adhere to a low sugar diet to prevent fungal overgrowth. Currently, she's lost about 15 pounds, and she has trouble maintaining her weight and nutrition. She also reports tongue inflammation and has been diagnosed with post-radiation atrophic glossitis with normal vitamin levels. Her past medical history, apart from the basal cell carcinoma, she also has a history of breast cancer, hypertension, hyperlipidemia, hypothyroidism, GERD, and coronary artery disease. Her vitals and physical exam were pretty unremarkable except for the bolded findings. So in general, she did have a pretty thin body habitus, and she did have in her oropharynx no candidal lesions at the time that she presented to us. She had that smooth tongue, reflective of the atrophic glossitis. And then she did have tonsils that were present. Her neck did have some palpable cervical lymph nodes and some palpable thyroid cartilage, which was thought to be secondary to her pretty thin appearance. And then also abdomen-wise, she did not have any masses or hepatosplenomegaly. So what differentials would you consider in this patient? Please feel free to chime in.
We'll give about a minute. Everybody that is in, please feel free to join and send your considerations. Okay, somebody mentioned CVID.
Oh, sorry.
Hi, everyone. It looks like we have some people raising their hands. If you could just pop your ideas in the chat, that would be great.
Oh, the chat is disabled. Okay.
Uh-oh.
So
It
please
should
go
be enabled.
I had a couple people reach out to me that the chat is disabled. I think only the panelists and host are able to see the chat.
Okay, let me see if I can fix this.
Thank you for being patient with us while we try to sort this out.
Okay, there we go. I think everyone should be able to use the chat. My apologies.
Okay, they're asking if you can briefly review the case because some of them may have missed some of the details. So a brief summary.
Okay. So this is a 73-year-old female. She presents to the AI clinic for basically low IgM. The level was 35 milligrams per deciliter and recurrent infection, specifically recurrent thrush. And she also has some weight loss of 15 pounds with decreased ability to maintain her weight and nutrition due to a low sugar diet. Her physical exam is really unremarkable, except for some palpable, maybe some thyroid cartilage, which we thought was secondary to her small or thin body habitus.
Perfect. Okay, so some of the differentials that have been mentioned are specific IgM deficiency, CVID, CLL, malignancy is 1, 2, and 3 at that age, hypogam secondary to chemotherapy. All great differentials. Good syndrome, DNA repair disorder. Thank you guys for chiming in. This is fabulous.
Great. Thank you, guys. So for us, we were considering some level of a combined B and T cell defect, considering her fungal infections and her decreased IgM level. So for us, we thought about mucocutaneous candidiasis, good syndrome, and the presence of anti-cytokine antibodies. Let me close this. Sorry. That might be her cause of her symptoms. So just briefly reviewing these differentials, for chronic mucocutaneous candidiasis, we were thinking without ectodermal dysplasia, as this patient does not have any skin, teeth, or skeletal abnormalities. And then for good syndrome, as we know, it's a thymoma with hypogammaglobulinemia, can present with autoimmunity, autoantibodies to various cytokines, invasive bacterial, viral, and other opportunistic infections, pure red cell aplasia, lichen planus, cytopenias, colitis, chronic diarrhea, and then also low or absent B cells. And then autoantibodies against IL-17 or 22 were also in our differential, which make patients prone to candidiasis and other invasive fungal infections. So talking as a teaching point about good syndrome, this is also called thymoma with immunodeficiency. It generally presents in adults greater than 40. However, there have been some case reports in children. It presents with an increased susceptibility to bacterial infections with encapsulated organisms and opportunistic fungal and viral infections. we do have some level of hypogammaglobulinemia with reduced or absent B cells, and then variable defects in cell-mediated immunity. So it's not a pure B cell defect. And these can be CD4 positive T cell lymphopenia, reduced T cell mitogen proliferation response, etc. And the pathogenesis at this point is not completely conclusive. The treatment is to resect the thymoma and also replace the immunoglobulins. But as expected with a combined defect, the prognosis is worse than a pure B cell defect such as an XLA or CVID, and death is usually secondary to infection, autoimmune diseases, or hematologic complications. And then for chronic mucocutaneous candidiasis, it's a spectrum of disorders which have an increased susceptibility to candidal infections. The most common one that at least I have read about is autoimmune polyendocrinopathy, candidiasis, and ectodermal dysplasia, or APSED, which is secondary to an ARI mutation. And then it's also, you can have chronic mucocutaneous candidiasis with hypothyroidism, or an isolated chronic mucocutaneous candidiasis. All of these have some form of Th17 response deficiency. And we know that the Th17 response is important for protection against candidal species. With APSED, these patients do tend to have, like mentioned in previous slides, autoantibodies against IL-17A, IL-17F, and IL-22, which are high in their plasma, which likely leads to the Th17 inhibition. So for this patient, the initial workup that we did, we got a CBC for her, and it did not reveal any cytopenias, and otherwise was relatively unremarkable. We did get pneumococcal titers, and for her, 8 out of the 22 were protective. One was unable to be performed due to reagent issues. And then ID, who saw her previously, did do some workup for other fungal infections and also for HIV, which were both negative. Her diphtheria and tetanus titers were positive. And then she did have that low IgM that was mentioned over here, although her IgG and her IgA levels were normal. Then we did a lymphocyte subset panel for her, and it did reveal low CD45RA and CD45RO absolute counts, but otherwise was normal. And then her Th17 enumeration study, which we pursued due to the chronic fungal infection, was essentially normal. And then we did a DHR, which was also again normal with a stimulation index of 91.4%. Interestingly, when we did the lymphocyte proliferation to mitogens, we saw that she had a decreased viability of the CD4 positive T cells and also decreased proliferation to PHA. And then when we did that for the antigens as well, again, we saw the low T cell viability, but her proliferation for Candida was also low, which was unusual since she currently had or previously recently had a candidal infection, and her tetanus proliferation was not, there was no proliferation. So because we were unsure of her last tetanus vaccine, she was vaccinated both for tetanus and pneumovax at that point at a follow-up appointment. Before her follow-up, she had developed about 3 episodes of shingles in the last 1.5 months. One of the lesions we did culture and was positive for HSV2. And she, after doing 2 courses of valcyclovir for the acute infection, she did end up on valcyclovir prophylaxis. She also had 1 episode of cystitis with a pan-sensitive E. coli, which was treated with nitrofurantoin. And then her only new complaint for this visit was that she had more mucoid stools with seeds that were floating, but she did not acknowledge any GI discomfort. So after vaccination and 5 weeks after vaccination, we repeated the pneumococcal titers, and it was slightly more protective, but definitely a suboptimal response of 11 out of 21 protective titers. Again, 2 of those were not performed due to reagent and lab issues. And then we repeated this proliferation to antigen study. And initially, this is the one that was done prior to vaccination. And after vaccination, you can notice that there is still that decreased viability of the T cells, as well as having a normal proliferation at this point to Candida, but a suboptimal response to the tetanus toxin. And then here is just a picture of the shingles lesion that she had. But because of her recent GI complaints, we were concerned about extension of her candidal infection to the distal GI tract. So we did obtain a stool culture at that time, and also E. coli 0157 antigen, and both of those were negative. And although 2 of the 3 differentials that we had do not have a monogenic cause for the disease, we did decide to pursue genetic testing. So what we found was that she had 2 variances that were noted. One was a NOD2 mutation, and then there was also an MLK1 variance of uncertain significance. So our impression for this genetic testing was that NOD2 mutations are associated with defects in intestinal mucosal defense, but not necessarily associated with recurrent candidal infections. So we didn't think that the in vitro panel actually revealed what was going on in this particular patient at this time. So just to review, the NOD2 mutations has been linked to increased risk of Crohn's, and we are pursuing a GI referral for this patient, although she really doesn't complain of any other GI symptoms apart from the mucoid stools. And loss of function mutations have been linked to decreased defensins and gut mucosa and dysregulated cytokine response. And although this may lead to the recurrent candidal infections, we don't know. However, does this explain the recurrent HSV? And it doesn't really explain the low T cell CD45 RO or RA levels either. And then MLK1 deficiency has recently been reported with impaired motility and chemotaxis of neutrophils. Now, the only testing we've done so far for that is DHR, which was normal, but we have not pursued other neutrophil testing. So the next steps for this patient, currently she's on antifungal and antiviral prophylaxis with fluconazole and valcyclovir. Per Dr. Chin's recommendation, we are going to pursue a chest CT scan to evaluate her thymus and also look for anti-cytokine antibodies. And then I think some of the questions that we had for the group as a whole was, one, would there be any benefit in pursuing B cell subsets, especially given that this patient had normal B cell numbers and protective titers in tetanus and diphtheria, although she did have a suboptimal response to the pneumococcal titers. Would there be any benefit in obtaining other T cell proliferation testing, such as with CFSE? Could there potentially be some benefit in IgG replacement, although patient doesn't really complain of any humoral type of infectious concerns with sinopulmonary infections apart from the diarrhea, which hasn't shown an infectious cause apart from the mucocutaneous candidiasis. And then although the PID panel did not reveal a unifying diagnosis, would further genetic testing be of value with something like a whole exome sequence?
Great. So, Dr. Chin, we would love to hear your comments on the case. Thank you, Malvika, for the presentation. This is still an ongoing case, so we basically would love to hear from everyone. If you have more thoughts, thank you, Dr. Khanna, for sharing this article. But Dr. Chin, please let us know what you're thinking.
Yeah, so, generally in 73-year-old women, right, it's going to be a lot less likely that you'll find a monogenic cause of considered chronic of course, there could be some sort of spontaneous but I mean that's in my mind really rare. I think it's going to be a lot more likely that there's a secondary cause to this. I guess my mic is not working. So
We can hear you a lot better now.
okay. So I was just saying, in 73-year-old, it's more likely that the cause will be a secondary cause than a let's just say underlying monogenic cause for this condition. I mean, it's just when you're thinking of genetic causes, right? I mean, you're running through things from STAT3 deficiency to STAT1 gain of function, but all those things. You would tend to find much earlier in life. You could always say there could be some sort of spontaneous event, right? Where, but then, even if the patient were mosaic, you would still have some normal cells floating around in the body. So, I mean, the panel test, I think, is really reassuring to me, but in that sense, from a genetic sense, but, that makes me a little bit more worried, like Scott Kenna was saying, what about a paraneoplastic process or something else that could be producing autoantibodies, right, to IL-17, or Good syndrome. The folks at the NIH studied patients with Good syndrome a while ago, and showed that those patients can make autoantibodies as well towards anything, but in particular against cytokines. So I think the top 3 steps listed here are definitely where I would start.
Great. Thank you so much. Okay, so Dr. Hartog is bringing up a question. That's a really good point. Like significant weight loss with bowel changes as like looking for secondary causes. So with weight loss has nutritional workup and labs done. Some level of workup has been done, but the main complaint in terms of weight loss has been the very restrictive diet that ID has recommended for her as a potential strategy to control the infection. She has been, in her own words, cheating in her diet because it's really difficult for her to stay strictly on that low carb, low fat type of diet. But not all the workup has been done. So this is a great point that we will bring up. She's up to date in her cancer screening. Yes, so far she has undergone everything. I believe that the last colonoscopy was done 4 years ago, but we are hoping that the GI referral would potentially lead to an update on that colonoscopy and everything else. So they're asking about the low sugar diet to prevent thrush. That's a really, really good question. Does anybody have like any comment about this? Because to my knowledge, last time that I reviewed that there was no like absolute indication to restrict, but this has been the very recommendation that ID has been very persistent on. So all great recommendations. Electrophoresis for clonality. For all candidiasis. Okay, so they're mentioning possible IVIG given like specific antibody deficiency like results. That is one of the thoughts. Actually, the patient herself brought it up because she wanted something else replaced. She was like, beyond the prophylaxis, what else can we do? And she brought it up. And that's one of the things that we wanted you all's opinion on. And giving her a PCV20, correct. That's a good alternative. Right, IVIG will not very likely help with the candida, absolutely. And that's why we have been a little hesitant to start it, because she has never had like pneumonia or sinus or that type of infection. Is more this candida. But it's one of those thoughts that keep recurrent. I think we're about to run out of time for our case, but I want to thank you all for participating. This has been tremendously helpful. There's one last comment. As an ID provider, dietary changes are not a recommendation and make as part of the treatment. Thank you for that. Let her eat whatever she wants. Perfect. Thank you all for your participation, your comments. Thank you, Dr. Chin, for your mentorship during this case. And I think we are about to transition to the second case. Thank you again for all your good thoughts.
Well, hello, everyone. My name is Natty Chamowitz. I'm a pediatric immunologist at Cook Children's. It was really fun for me to hear about a case of a 73-year-old, because I rarely think about immunodeficiency in adults. Our second case will be presented by Dr. Nicholas Rister. He is a pediatric infectious disease doctor at Cook Children's, and our senior mentor will be Dr. Ashish Kumar. He is a professor of pediatrics at University of Cincinnati and the director of the Histiocytosis Center at Cincinnati Children's Hospital. So Nick, take it away.
All right. Thank you for the introduction. Thanks for having me, everyone. Like Natty said, I'm an infectious disease doctor by training, so this is a kind of a nice treat to be able to present to you all. And thank you to Dr. Kumar and Dr. Chamowitz for keeping me on the rails, hopefully, for this. So we'll dive right in. I titled this one Rock and Roll All Night. Hopefully that's a little bit of a clue for y'all. And this one will be hopefully a fun ride. Yeah. So this is a 5-year-old girl. I'm a pediatric infectious disease doctor, so we're switching the whole spectrum now. She was transferred to us from an outside facility for concern for sepsis. So a little history. This isn't exactly to scale, but since like many pediatric patients, she had a pretty long history of kind of viral prodrome with things long before she actually made it to us. So on the October 1st, she developed a cough and fever, looked like she had otitis media, got put on some amoxicillin. Several days later, not feeling better, more fever, more fatigue, not drinking well, showed up to her pediatricians, got COVID, strep, and flu. They were all negative. So the following day, when she's still not feeling well, got sent to the ER, had a negative chest x-ray. They switched her amoxicillin to Ceftonir, gave her some Zofran because she'd been nauseous. But the following day, new onset of neck swelling on the left side and a rash over her back and her neck that her mom noticed. There was some concern that maybe she was developing an allergy, so they stopped the Ceftonir, gave her some Benadryl, but just not getting better. Still having fevers, rash is progressing, just not eating, now having a little bit of loose stools, just feels miserable. So ultimately gets referred back to the ER a couple days after that. So we're now about 9-10 days into this illness. At that time, the neck swelling's a lot more impressive. So they do a neck CT, looks like cervical lymphadenitis, but no abscess, no collection that they need to be draining. A respiratory panel had enterovirus rhino positive, which sticks around for months. So that's a very common finding, of course, but potentially involved here. given the adenitis and the persistence, they went ahead and admitted her on IV clindamycin. She wasn't at the hospital more than 12 hours before she started having some borderline low blood pressures, looked like she was going to need pressors, had some elevations in inflammatory markers, and they got nervous. They sent us here for a tertiary care center. Got to our PICU because of the blood pressure concerns, was on pressors for just momentarily, not very long, matter of hours, but was on IV vancomycin and ceftriaxone with just concerns for the generalized sepsis and developing illness. So then they consulted us. So not a very exciting history, 5-year-old, healthy, no major medical issues, lived with her parents who were separated, but everyone's pretty healthy, has a brother who's healthy, pet dog, moved from California earlier in the year, but nothing really to report. On exam, she looked miserable, but she wasn't toxic. She was tachycardic, she was breathing hard and kind of coarse throughout, but was moving air. Had a little bit of splenomegaly we appreciated on exam, and the rash itself was petechial. It wasn't too impressive, but it was on her neck, her back, and then had spread out on her chest and her arms and legs a little bit. Had some red eyes and swollen tonsils, but what was really impressive with her is that all of her lymph nodes, not just her neck, were distended, were large. So not just neck, submental, tonsils, under her arms, her elbows, her groin, all those lymph nodes were actually swollen. They were mobile, they felt reactive, but impressively generalized. Got some labs. These are all kind of things that were trending in that first day she was in the PICU by the time we saw her. Had a pretty impressive lymphocytosis with that white blood cell count, a little bit of anemia, thrombocytopenia. The inflammatory markers actually weren't that bad. Some elevations in procal and CRP, but not nearly as high as we could see with a lot of things. Liver was a little irritated, we could see there. Ferritin was impressive, 3,700. Got a chest x-ray, because of course you got to get a chest x-ray. That actually looked pretty clear. It looked like every pediatric chest x-ray, peribronchial cuffing, asthma versus viral process, but had a little bit of thickening down on the lower right side above the liver. So they got an abdominal ultrasound wondering if something more was going on with the liver, but really all they saw, other than some mild enlargement of the liver and spleen, was that the lymph nodes, again, of the liver, and pancreatic head surrounding that area were enlarged and reactive in appearance. So I'll pause here if anybody wants to throw out any thoughts or different things, and make sure I can see the chat. And I know Natty and just keep an eye on things too.
People are saying EBV, HLH, Kawasaki disease, MISC, EBV-induced HLH. I see a pattern.
Man, you guys, you could be pediatric infectious disease doctors already. I know this is exactly what we were thinking. The generalized adenopathy and things. But we'll go a bit through the thought process. So let's just keep on moving, because I think we're all on a very similar thought process of what's going on with this kiddo right now. So quick step back. So whenever someone comes in with sepsis, especially with peds, these kids compensate really well hemodynamically until they don't. So even though I had a strong suspicion, like we're talking about for like mono or potentially developing HLH, you don't want to miss a bacterial sepsis and meningitis. And a lot of times in young kids, it's not obvious at first, and then they just crash. So I always run through a differential like this. When someone comes in, they need to be put on pressors, even though they're not necessarily the things I'm like immediately thinking about when someone describes the patient to me. So you do not want to miss bacterial septic shock. You can't miss meningitis, toxic shock, viral sepsis, of course. But then there's other things, is there an uncommon exposure? ID doc, we ask all our exposure histories, were they just swimming in a lake 2 weeks ago? Have they traveled somewhere? There's a lot of diseases that go along with that you will miss it if you don't think about it. Same thing, immunocompromised. I did not suspect she was immunocompromised from that initial history or anything, but I'm always running through my head, is there something weird about this? Is she more hypoxic than I expect, thinking PJP or anything all along those lines? I think about this more often than I probably need to, just because we all have those cases that we miss because we didn't think about it up front. But that being said, this kid has generalized adenopathy, fever, increasing inflammatory markers. So I'm going to some of my more usual infectious, HLH, of course, we were also, wondering about that with a ferritin elevated and things. We start thinking, like, could we explain it from an infectious standpoint? Mononucleosis, of course, generalized adenopathy, fever, EBV being the most predominant, but also CMV and toxo, play a role there. You can have bad group A streptococcal bacteremia for sure. If it had been a vesicular rash, we definitely think about HSV and VZV all the time. Although we didn't have vesicles here, you don't always at first Disseminated adenoviruses can look terrible. This wouldn't be a absolutely inappropriate appearance of that. This, the 5-year-old, so I'm not thinking sex, drugs, rock and roll kind of stuff, but in the right patient subset, that would make sense. Geographically, certainly the endemic fungi can do all sorts of bizarre things. If you're in the right, travel history, malaria can certainly look like this. Exposure wise, she didn't have any too unique things. She wasn't at any cattle births or hunting rabbits or swimming with her dog and things like that. But I mean, you got to ask. You'd be amazed how often people say yes to stuff that you never thought they would. So,
and in the chat, somebody commented that leishmaniasis can look like HLH as well.
Yeah, and leishmaniasis is definitely one of those that goes in the uncommon, but if you have the right travel history, right exposures, absolutely can look like that, because you gotta ask. Maybe not the first question, but eventually someone should ask it. So at this point, I'm like, okay, this could just be a really bad disseminated Epstein-Barr acute mono infection. That's how she looked. She looked, rough for it, but not certainly plenty of cases can be like that. Initially, that's what we're thinking. We're like, okay, if this is acute mono, let's see how she's doing. Let's watch her, because she was actually doing a little better. It seems she'd stabilized. She had gotten off pressors. She was on antibiotics for a bit longer than we'd expected. That finding on ultrasound of enlarged lymph nodes around the pancreatic head and stuff, there was some concern maybe there's an abscess or something there. Really, on further review, that wasn't the case, but that's why she was on ceftriaxone metronidazole for a couple days longer. Certainly not what we would normally do if we're thinking more viral. But then she's just not getting better. We're now 2 weeks into this, and the whole time she's in our PICU, we're just watching her stay extremely febrile, and we're seeing some abnormalities in her labs worsen, which we're going to show in a second. So we did a pretty extensive workup at this point, especially more towards the immunology inflammatory end of things, because I felt like I had my answer as far as the infection with the mono. So again, that lymphocytosis we're seeing more anemia, more thrombocytopenia. Again, we did confirm the mono. Our Epstein-Barr viral load was pretty darn high, a log of 4.79. So this is definitely an acute EBV infection as part of this. The liver didn't get that inflamed. It actually calmed down a little bit more so than we often see, even with disseminated viral infections in general, like EBV. But along the lines we were thinking, we have a low fibrinogen, an elevated D-dimer, a ferritin that's now risen up to 7,500, elevated triglycerides. If you look at the subset panel, we got, our antibodies look good, but our subsets showed, a lot of T cells, not a lot of B cells. There's some discussion of like, is that because the B cells got destroyed by the mono? We're not seeing them. This is all plasma EBV now, or is this a T cell EBV? That can be an interesting thing to tease out, but there was some discussion there as well. But working up further for this, what this inflammatory condition is going to be, soluble IL-2 receptor, very elevated, CXCL9 is very elevated at 40,000. Granzyme B is elevated in NK cells, but very much present. We get a bone marrow on this because, of course, we're wondering, and there's no hemophagocytes. We do our NK cell function testing, comes back, minimal, absent, but of course, that can be very finicky. All right, so before we get further into discussion, I'll just show we did do a full body PET and CT scan, showed lymphadenopathy everywhere. Basically, that's the moral of the story with this. Every lymph node was a bit swollen, but again, no focal lesions, just enlarged. And that's big for me. The hepatosplenomegaly, it's important for me from an infection standpoint that we're not seeing specific focal abscesses or defects or something that might suggest some unusual infections or push me to go into another direction as well. This is generalized adenopathy. So I'm gonna leave it open to discussion, but I'm gonna go back so we can see the laboratory studies while we chat.
Before we get to that, people are wondering how you measure NK cell function, whether it was cytotoxicity of CD107A, and also IL-18 levels.
Natty, I don't know. I'm not sure off the top of my head. I know the answer to if we got IL-18 or if we.
I'm pretty sure we got it, and I don't remember the number. It was elevated, but not impressive compared to CXCL9. The NK cell function versus minimal to absence, that was cytotoxicity. And let's hold off on the question about NK cell degranulation. So what are people thinking now? Somebody is asking, did you calculate the H score? I'm not really sure what the H score means.
Yeah, thank you for saying that. Again, everyone, thank you for Dr. Chamowitz, Dr. Kumar for being here to field some of these, because you guys will outclass me quickly with some of the immunology testing.
People in the chat are recommending sending an HLA genetic panel. And that it's much less likely that it's an X-linked form of familial HLH, given that she's a girl.
Yeah. I think I'm feeling from everyone that we're still highly suspicious for HLH despite not finding our hemophagocytes, but now teasing out exactly what flavor this we're dealing with, which is a lot of the discussions we were having at that time.
The H score is a score developed to generate a likelihood for HLH. Thank you for sharing that. The H score was derived from adults, about 50% of them with malignancy. And then people are also suggesting sending genetics as well as CD107A and then starting treatment. Thank you for including the link to the scoring in the chat.
Yeah, thank you very much.
I think, Nick, we can move on.
All right. So following the workup, to complete things, we did actually go after one of these lymph nodes that was pretty readily accessible in the axilla. This tested wildly positive for EBV, which makes sense, but also clearly at hemophagocytosis. So at this point, we're thinking an EBV-related HLH. And of course, we're going to do some of the testing we just talked about. This looks like one of the kids I take care of drew it, but it's just a brief review of HLH, which I know most of you are very comfortable with. So of course we're looking for, but it never hurts to review. So of course we're looking for our natural killer cells and cytotoxic lymphocytes and their ability to kill our activated macrophages, or at least tell them to kill themselves through apoptosis. That provides that normal downregulation you expect. They do this through perforin-mediated cytotoxicity. They release granules, degranulate granules full of granzyme B and perforin, which then signals the macrophage to undergo apoptosis and calm down that inflammatory response. When this doesn't happen, I mean, it can happen for all sorts of reasons, whether you're not making granzyme, you're unable to degranulate, you're unable to even match up with the macrophage and the NK cell and have them talk to each other in the first place. All those can be, the genetic basis for this, but at the end of the day, it leads to an abnormal immune activation and overactive persisting inflammatory response. So Natty shared this with me, and it's been very helpful for a lot of these cases that have come up. This is outdated, of course, but I really like the way it breaks down, the familial kind of primary HLH versus the secondary, and specifically like EBV being a very common secondary trigger for HLH. And that's, I think, in a lot of cases, what we were thinking for this patient. We had a primary, we've proven that, EBV infection, and now we have this developing HLH. So that's one of the things we started thinking about, although a lot of those are X-linked, which we're not necessarily suspecting because of the female gender, but we didn't have, this is a 5-year-old. It's not a 2-year-old presenting in more of a classic primary situation. And then, as far as the syndromes associated with HLH, we didn't have any abnormal physical exam findings like, hypopigmentation for Chidia Kagashi or one of those to really push us along those lines. But of course, they're on this as well. The reason I use the outdated one is I'm sure you guys know it is wild how many new genetic disorders have been identified even over the last 10 years. And I imagine this scale is going to be broken in 2 more years. So you constantly reinvent that chart. So getting to what I think a lot of you want, we did send genetic testing. So we sent the full inborn errors from Invitake. And what we ended up seeing, surprisingly, was 2 variants in STX-BP2, so familial HLH. One of them was pathogenic, one was uncertain. And then there was also a pathogenic variant, LIST, which is associated with Chidia Kagashi. But again, that didn't really fit at all with the presentation of exam findings for this patient. But this familial mutation was very concerning. But again, really odd. This patient was 5, had no major medical history, had been sick before, and had dealt with it just fine. And this is an acute EBV. This is generalized adenopathy. This wasn't like a remote trigger or something like this. This is like in the moment EBV transitioning into full-on HLH. CD107A testing was abnormal. I'm going to show you that in a second. For CD107A, for those, I mean, I appreciate everyone explaining this along the way. This is actually extremely useful to me. The CD107A marker is actually on the granules within the NK cells. And when they're released, those markers then merge with the outer cell membrane. So at base, an NK cell shouldn't have much expression, but once they're stimulated and those granules release, they now should show expression all over the outside because the granule membrane has now merged with the outer membrane of the cell itself. So in the control, you see, baseline 3%, well, it's stimulated closer to 20. In our patient, the baseline around 3% only went up to about 5-6%. So definitely showing signs of lacking degranulation. Before we get to our next discussion moment, just to give you a quick idea of what we did for this patient, got started on rituximab, got dexamethasone, responded beautifully. Within 24 hours, maybe 36, defervesced entirely, started feeling dramatically better. There were discussions, the next step being Gamifant, whether we were going to do that, but we had such a rapid response that we initially actually did not give Gamifant. So I'm going to pause here because I think we have a lot of questions at this point.
Yeah, there's been a lot of awesome discussion in the chat. I'll summarize the main points. People are discussing that really sending an 18 gene panel, an HLH panel is really not sufficient, being that there's so many different disorders beyond that can present with HLH. People are recommending sending either rapid whole exome or rapid whole genome. People are also, there's also discussions about insurance coverage when you expand beyond the HLH genes. And people are mentioning that usually these patients are inpatient, so genetic testing is billed together with the admission. In our institution at Cook Children's, we tend to rely on Invita panels via sponsored testing to get that covered. And then a comment here, and I'm sure Dr. Kumar will touch on it a bit more, is that despite this patient, impaired termination of immune synapse is not really implicated as a mechanism for most cases of EBV HLH. And most cases of familial HLH are not really triggered by EBV. There's a question about the segregation of the variants, and the variants were in trans.
Yeah, exactly. So this was, as far as the familial gene, one from mom, one from dad, the known pathogenic, and then the unknown significance, but got one from each parent. And Dr. Kumar, someone had mentioned that, of course, the LYST was just a single mutation from one of the parents, so unlikely to contribute much, which is what we expected as well. So we felt we had an explanation for the HLH, but it was very unusual for it to be familial in this setting.
All right, we can move on.
All right. So this patient kept on giving more and more surprises. So at this point, not only initially we were happy with the Epstein-Barr explanation, then we were like, okay, we have an EBV secondary HLH. Then we have this familial concern, but we're like, at least we have diagnoses that we can treat, and we have a firm understanding to some extent what we need to do. But then we get a surprise from this lymph node biopsy, and that we see acid-fast bacilli on it. Now, this makes so little sense. So we had done TB testing, because when we think acid-fast, you're thinking mycobacterial. There are other things that are acid-fast, but I'll just, for brevity here, we're thinking mycobacterial for this patient. And of course, we had done TB testing with all the immunomodulators, and that's negative. But there are a ton of other atypical non-tuberculosis mycobacterium. This was a really strange finding too, because it wasn't even throughout the entire lymph node we sampled. It was on the microbiology sample sections, but it wasn't on the pathology sections. We went back and looked several times, so it was really spotty. Kids, young kids especially, get atypical mycobacterial lymph node infections not irregularly. We see that pretty commonly in clinic, usually just a single lymph node, very commonly a cervical lymph node that gets excised. There are a lot of these are soil bugs, that a combination of them being young, developing immune system, down in the dirt a lot, it happens. But this was just really unclear how much this even played a role, but it was definitely there. So we don't know what this was. They take a long time to grow, if they ever grow. but these nodes weren't necessarily acting like that. It's not a common trigger for HLH, even familially. So it really is bizarre. And this patient's responding wonderfully to immunomodulation and not, clearly showing disseminated mycobacterial disease at this point, although it's early. But you can't ignore it. So the question, I think someone mentioned, kids do not usually get diffuse mycobacterial infections, and that certainly does not seem to be the case with this patient. Even within that singular lymph node, it was very spotty. So there's a question of whether this is just a lymph node we happen to get that happened to have been exposed to mycobacterial from the environment, and had, if anything else had gone on, this would have cleared, and we never would have even known about it. But this is a patient we're talking about even going on Gamifant and things, so you cannot ignore this, and it's really unclear what role it's playing. Like I said, this was a wild ride of a patient. Now there are plenty of acid-fast, atypical mycobacterial infections. They all generally need to be treated differently. Ideally, you can grow them, you can test them, but in this patient, we didn't have that luxury because we're doing profound immunosuppression. So we have to come up with a regimen to treat empirically, just in case we're about to set off a bomb of disseminated mycobacterial disease we weren't expecting. So in this case, this is sort of the regimen you would do for someone who's profoundly immunosuppressed or having very severe disease, where you may choose IV something like amikacin, which is what we did here, and then a couple of other oral drugs, ultimately transitioning to at least 3 different oral drugs after this initial IV induction period. A lot of these drugs have a lot of toxicities, and we're talking weeks, months, many months of therapy for some of these things. So this was a really interesting one. Our patient ultimately is still on oral ethambutol, azithromycin, and rifampin right now. That's a common regimen, more along the lines of like a mycobacterial avium complex and some of the other slower grower bugs. She's doing very well. She tolerated her steroid wean and did excellent with that after getting her rituximab and steroids. We're planning for a bone marrow transplant given the familial gene and the fact that she's already declared herself in this way. I'm not sure how long I'm going to treat that mycobacterial infection. It still may grow at some point. These take forever. If anyone has a preference, throw it at me. I would love to know how long you might treat this, but I'm going at least 2 months. And Epstein-Barr viral loads fell very rapidly after the treatment with rituximab, as expected. Also want to add that we were able to genetically test brother. Brother's also a carrier for both of the genes in trans, just like sister. So there's been an ongoing discussion about what to do for brother, who has had no medical problems whatsoever. So there's an argument for watchful waiting versus preemptive bone marrow transplant. That's an ongoing discussion. I'll pause there for a second.
And we have Dr. Eames, who is our BMT doc at Cook Children's, and she says the plot thickens because her CXCL line that had been decreasing has now increased above 10,000. Like Nick just mentioned, the brother has the same genetics. And now, we just got those results today, so I agree with you, Ivan. We will be sending CD107A, but I suspect it'll be also abnormal. We only have a few minutes, but I would love to hear Dr. Kumar's thoughts on this case.
Thanks, Natty, and everybody. I think there's not much left to say other than this case shows the power of the flow assays, CD107A specifically, because one of the STXBP2 variant was a known mutation, the other one was a VUS. And whenever you see that, you don't know, are you dealing with a biallelic deficiency or is this patient just a carrier? And that's where the flow assay for CD107A becomes very critical. And I also want to point out there were several discussion points about H-score, how to diagnose HLH. Please read Dr. Scott Canna's comment. That is the most important takeaway from this case, besides the flow cytometry assays, that most cases of HLH actually are not caused by EBV, despite what the papers from China say. And EBV HLH is not just one disease. There are definitely 4 or 5 different phenotypes under that umbrella of EBV HLH. And one of them, it is just a severe case of mono, which initially, the initial thought in this patient would have been absolutely correct. But because this was more than just a severe case of mono, because she just was not improving, and now we know why. So that's all I would say. That remember that the flow assays are important, and there's a lot more discussion about what is HLH, what's the utility of the H score, and in my opinion, the H score, all it tells you is that the patient is inflamed. It's not, HLH is not a diagnosis; it is a description. The diagnosis in this patient is STXBP2 deficiency, or familial HLH, if you want to say. And given the how close we are to the 9 o'clock, I will end my comments here.
Okay, well, thank you so much, everyone, for the wonderful discussion. I certainly have learned a lot, and I really enjoyed all the participation. Thank you so much, Nick, for presenting, and Ashish for helping us along with this case. And also I want to thank Juanita, Ivan, and Malvika for their case as well. There is a question in the chat about, do we transplant the brother before he has a trigger and becomes asymptomatic, or we watch and wait? So I'll leave it up for 1 more minute. And people can put on the chat what they think. Do we transplant the brother, assuming that his CD107A is abnormal, before he presents with HLH, or do we wait?
There's actually data for that, Natty.
For yes to transplant preemptively?
Correct. The evidence, because this question has been faced by physicians throughout the world, and Rebecca Marsh collected the evidence. The numbers are not that high, but overall, when transplants were done before the children ever developed HLH, the outcome was better.
Okay, interesting. All right. Well, I think we can now wrap up, and thanks again for participating. It's been a wonderful discussion. If you guys have any cases or presenters that you would like to recommend, you can send it to the CIS info box. I'm putting the email address in the chat. If you guys have any questions, suggestions, please reach out to us. And with that, I hope everyone has a great night.
Natty, to leave everyone with a really bad joke, my title was an allusion to Rock and Roll All Night by Kiss, and of course, mono, the kissing disease. So had to leave everyone with that bad one because I made the slide.
Nice one, Nick. That was much better. Go listen to a song called Mononucleosis is the Kissing Disease. Then we can talk more later.
All right, sounds good. Will do.
Take care, everybody.